What is reference-based pricing and is it for me? Can I explain that in 15 minutes or less? I get asked that. And here we go. We're going to try. I'm not sure if I totally can, but we're going to give it a go right here. So what is reference-based pricing? You got to start with a handful of questions that I think are really important for employers to think about when they think about, should I engage in reference-based pricing? The first question is, why do you as an employer pay 3 times what Medicare pays for the same exact services at the same exact facilities? Why does the American healthcare lobby spend $700 million annually? It's the most in the United States. It's the largest employer in the United States. It's the largest lobby in the United States, and it's the largest individual segment of the US economy. Third question, why are the 5 largest health insurer stocks up 1,900% since 2009 when the S&P 500 is only up 420% over that same time frame? Why 2009? That's the year before Obamacare became law. And when I say 1,900%, I'm not talking in aggregate. I'm talking about the fact that that's the average independent increase in premium these health insurers are seeing individually, okay? Why is your renewal 8 to 12% every year when the true costs really only going up 1.5 to 2%? Why do you pay $22 per employee per month in the form of a network access fee for the privilege of a 50% discount on something they've marked up 600%? When was the last time your experts showed you a truly revolutionary new method for reducing your healthcare plan spending by 20 to 40% in the first year with no loss in quality? My name's Craig Gottwals. I've been doing this 22 years full-time. I'm an attorney. I'm an university instructor. And this is what I do, folks. At this point in my career, I work for fun because I like to do it. And I find this incredibly exhilarating. And I love saving healthcare plans for the employer, one plan at a time. Okay, let me move my ugly mug out of the way to make this a little easier to see. This is just a visual depiction on what's going on with healthcare and what's been going on the last 23 years on this slide. This is from the Kaiser Family Foundation. This is independent data. This is not my data, okay? So I just drew a line here in the middle of when Obamacare became law. Remember, Obamacare was going to rein costs in? Not so much. So at the very bottom in royal blue, cobalt blue, whatever we want to call that, that's how much general inflation has gone up since 1999. Dark blue shows what worker earnings have done since 1999. Who says 1099? Anyway, all right. So family premiums are up 288% in orange, and how we're hammering our employees and we're destroying our own compensation model, that's in yellow, 296%. This is what the last 2 decades in healthcare have shown us. And this is why I have dedicated my career to stopping this one employer at a time. All right. So I just grabbed the 4 largest health insurers here to show you. This is what their stocks have done. In this case, I pulled since 2005. These are the 4 largest healthcare insurers, and this is the visual depiction of what their stocks have done since 2005. Remember, Obamacare became law 2010. And each one of these, if you average them all out, it's up 1,900%. Each one of them is up 1,900% since 2009. I'm sure, look, I'm sure you're experiencing that in your business, right? Come on. This doesn't happen in a free market. It just doesn't. This happens in an oligopoly where there's collusion and there's price fixing. Sorry to say it, but this is not what a free market looks like. We have to exit this system if we want to free up our health plans. There are only 2 other systems I can think of that are even close to this, and that would be college tuition and maybe your electricity bill, your utility bill have gone up this much in that amount of time. All right, so what is a savvy CFO like this lady off to the right to do? This is what reference-based pricing looks like in one slide. This is an oversimplification. This is one claim. I just want to show you what's going on here. So first and foremost, you have a hospital that sets what's called a charge master price. It's their retail price. It's the pie in the sky, unicorn riding, cotton candy eating, utopian price that doesn't exist. Nobody actually pays this unless, of course, they have no insurance, they have no social safety net, They have no negotiation skills. And on top of all that, they have a ton of money to just pay whatever's asked, right? So it's completely bogus, but it's what they do. They set these prices incredibly high because they know nobody's going to pay it. And then they know they can give a 50% discount on that price. And one of those national healthcare insurers, one of those logos you recognize that we saw on the last slide, can claim, we're getting a 50% discount. This is great. So everybody's in on this game. They love it because it allows everybody to say, we're negotiating a 50% discount for you. Isn't this wonderful? And then you come along and you pay $22 per employee per month for the privilege of that. Here's the reality. I've worked with many CFOs in my career, hundreds of them, and I've worked with a dozen or so hospital CFOs. And to a man, just about every single one of them has told me, Craig, we can make money at Medicare. We have to be more efficient. We have to tighten the belt up a little bit. We have to do things a little smarter. We might have to eliminate some of the bureaucracy we have, but we can make money at Medicare. Okay. So why are you paying 3, 4, 5 times Medicare if that's the truth? You don't have to. This is the biggest scam in the history of healthcare, that you don't have to pay this and you don't know it. She knows it. That's my client. She knows it. She doesn't pay $5,000 for this claim. She pays $1,400. Why $1,400? Because our program on average is going to reimburse that claim at 40% more than Medicare on average. This is an oversimplification. The reimbursement might be 10% more than Medicare. It might be 200% more than Medicare. That's going to depend on where you are in the country and what procedure is being done and the level of the expertise of the professional doing that procedure. But we've worked all that out. We know this works. So just to give you that idea, my client is going to pay $1,400. Now, Medicare would pay $1,000 for that claim. And just to round it all out, on average, every state's a little different. In some states, Medicaid actually pays more than Medicare. Medicare is what we use for our senior citizens. Medicaid is what we pay for low-income folks. In California, Medicaid pays 20 to 25% less than Medicare. That's not true in every state, but just to give you an idea of what's going on here. Medicaid, when it first became law in the mid-1960s, was designed to cover the lowest 2% of earners in our country. Today, it covers 1 in 3 babies born. That's right. That's what a federal government entitlement bureaucracy creep looks like. Creep being expansion over time. I don't mean there's like some individual weirdo out there. Anyway, so this is what it looks like. This is how a single claim gets paid in reference-based pricing. We just throw away that garbage price up at the top. It means nothing. Frankly, the PPO discount means nothing. We look at Medicare and we build up from there. How is Medicare set? Medicare prices are set at the federal level annually. Any hospital or facility that wants to be reimbursed by the federal government has to submit their actual costs to Medicare. When they do, Medicare uses that to set the reimbursements county by county, hospital by hospital. It's a very detailed process. And by and large, it pays roughly what needs to be paid for these services to be rendered. You will hear hospitals scream, we can't function at Medicare. Then why do you take it? Right? Why? You don't have to take it. There's no law. There's no gun to your head that says you have to take Medicare. Don't listen to that, folks. Look at the data. Let the data show you what's really happening. And I'll show you on the next slide how much hospitals really take Medicare. Okay, so again, I got to shrink myself here. It's too large. There we go. A much smaller version of me is better for everybody. It's better for everybody. I can tell you right now. Okay, so regarding access, this is what the data says. This is from the Kaiser Family Foundation, KFF. Again, it's not my data. It's publicly available. Pull it up on your own. Everything on the left, this is telling you the percentage of providers that will take a new patient on Medicare in orange. On the right, you'll see the percentage of providers that will take a new patient if you have a private insurance plan, 90% of the time funded by one of those giant 5 logos or 4 logos we saw a couple slides back. Okay, yeah. Do more doctors prefer private insurance? Yeah. Let's look at a family practice. It's a 2% difference. Okay. Let's look at general surgery. It's a 3% difference. Let's look at OBGYN. It's a 6% difference. Look down here at psychiatry. You actually have a better chance of getting a doctor if you're on Medicare than in the private world. So don't let anybody tell you nobody takes Medicare. Don't let anybody tell you Medicare's so low we can't make money. That is not true, folks. I've seen it over and over through my career. Couple other things to keep in mind. Now, some savvy person out there might say, yes, but Craig, probably these facilities and doctors are taking Medicare because out of altruism. It's the right thing to do. Yes, they're losing money on it, but it's the right thing to do to support our healthcare system. Okay. I doubt it. Maybe. Sure could be the case in some cases. Two counterpoints. One, we're not going to pay 100% of Medicare. We're going to pay 140% of Medicare. So we're going to build in a nice fat margin saying, hey, look, if you're operating at the razor's edge at Medicare, we'll pay you 40% more, right? So that's one thing. Two, remember, Medicare, it covers our seniors. It's the oldest people in our population, i.e. the sickest people, the most challenging ones. We're going to be bringing in employees, 20s, 30s, 40s, 50s, much healthier on average than Medicare, and we're paying 40% more. So we're bringing in healthier people. We're paying 40% more. You think we're going to get acceptance? Yeah, we do. In fact, 90 to 98% acceptance, first pass, without even having to use our concierge service to assist your doctors and hospitals in understanding why this is the right thing and why this works. The next slide, I think, yeah, this is just, again, moving the ugly mug out the way. This is just another visual depiction of how many providers are accepting Medicare. Okay, so again, just so you could see, anything in that dark blue is fantastic, where you're getting large acceptance rates on Medicare. Don't need to spend a lot of time on this slide. It was really covered on the last slide, but this is just gives you a more geographical look. I happen to be in California. We have clients all across the United States. People have always thought, oh, you can't do reference-based pricing in California, Craig. It's too tough. I say nay, nay, in homage to my favorite comedian, the late, great John Panette. Yeah, I'm in the orange, right? I got yellow all around me. Utah, Oregon. We rock RBP all day long, folks. It's not an issue. It's lazy consultants that don't want to dig in and do the right thing. It's those folks that say you can't do RBP in the West. It ain't right. You can do RBP in the West. We are, and we're crushing it. Okay, so a couple examples. What does it mean to you? What happens with RBP? Again, just a couple examples. Aurora, Colorado, all the way to on the left side here. It's my left. Maybe it's your right. Who knows? Aurora, Colorado, we had a 22-day hospital stay. When we have claims this large, we audit them line by line. Okay, so when it was all said and done, $520,000 was billed. We paid $40,000 for a plan savings of $480,000 or 92%, accepted, no problems, right through the system. Now, had this been a national insurer, the average would have been $250,000-ish, probably, because they would have roughly paid half of that $520,000 price tag. Smaller claim on the other side, we're looking now in Austin, Texas, all the way down at the bottom, saving summary. Total billed charges, just under $200,000. What did we pay? $3,000. This client saved $195,000 on one claim. One claim. It's incredible, folks. It's incredible what we can do with reference-based pricing. Is it harder? Yeah. Does it take learning? Yeah. Get a broker, get a consultant that knows what they're doing, and evaluate it. At a minimum, evaluate it. This will save 20 to 40% on your healthcare plan in year one. And then you're only going to inflate at 1.5% to 2% because you're tied to the Medicare reimbursement going up, not the 8 to 12% more you pay every year right now. Plus, of course, this is a self-funded platform. You own your claims, you own your data. It just becomes a much better way for you to pay claims. Last slide, one more example. Senior Living Center cut costs by 36% in the first year with no reduction in benefits. In fact, when we install these, I always make benefits a little better. I reduce copays, I reduce deductibles. Why? I want employees to be excited. I want them to see, hey, this is cool. Now I get this like white glove concierge service where human beings answer the phone and help me, and I pay less for healthcare, and I've experienced no takeaways for the most part. I mean, you know, there might be 2, 3, 4, 6% of takeaways where you have to find a new doctor. That happens, but it's not as much as you think. It's never more than 10% of takeaways in doctors, I'll tell you that. So during a year when the head count went up, by 6%. This 1,000 employee group saw their costs drop by 36%. What did that mean to them? $3.8 million in savings.